Good day, everyone. I'm Harry, your moderator for this webinar. I welcome everyone for today's webinar, which is called Dietary Food and Nutrition Services Meeting the CMS Hospital and CAH, CoPs, DNV Healthcare, and DNV requirements. I would like to now present our presenter for today. Her name is Laura A. Dixon. She is my favorite speaker now. So Laura Dixon served as the Director, Faculty Patient Safety and Risk Management and Operations for CoPs from 2014 to 2020, where she provided safety and risk management consultation and facility practitioner and staff in multiple states. Ms. Dixon has more than 20 years of clinical experience in acute care facilities, including critical care, coronary care, perioperative services, and pain management. So I would like to now hand over the floor back to our speaker. Over to you, Ms. Dixon.
Well, thank you very much for that very nice introduction, and welcome everyone to this program. As David mentioned, it talks about the dietary standards for CMS and Joint Commission, and it's really what hospitals need to know. Now, you probably think, why are we talking dietary? Because dietary does have such an impact on the overall condition of a patient and also the operations that go on. And so that's why CMS really dedicates an entire section to dietary regulation. So what are we talking about today? And let's start off just with dietary errors, because they do happen. CMS can come in and investigate whenever there's a complaint of dietary errors. Now, we're not talking about the food tasted bad or the food didn't have any flavor. That's not so much what we're talking about. CMS will come in and investigate when there's something much more extensive. For example, a patient received a medication or a meal and included something that they were allergic to. The Pennsylvania Patient Safety Authority also examined dietary errors that occurred. They looked at it over a 5-year period, and they found almost 300 errors in that 5-year period from 2009 to 2014. There are other type of errors that occur with diet. Of course, it's the wrong diet. Let's talk about the conditions of participation for dietary and nutrition services. Conditions of participation are just that if you have a hospital and you're a member of a hospital, and you want to participate in receiving Medicare and Medicaid benefit for patient care, then you have to comply with the conditions of participation. And they have a separate manual that encompasses all types of facility. Each type of facility has a separate appendix. For hospitals, it is Appendix A. For critical access hospitals, it's Appendix W. Now, the thing is with CMS is you have to follow all of these regulations no matter the patient or their payer. So it doesn't just apply to Medicare or Medicaid patients. It's all patients, your private pay, your indigent patients. This is the State Operation Manual Overall Index. This is Appendix A for hospitals. That's usually your over 25 beds and more. So let's talk about deficiency reports. This is what it looks like when you hit on the link for the deficiency data. You'll scroll to the bottom of that page. There are 2 Excel documents. One are for facilities. Hospital. The other is for your dialysis centers. Go to the hospital one. By the way, it's a very long Excel document, but you can filter and sort according to tag number or even location if that's how you wish to do it. And then it will bring you up all the deficiencies. As of last week, late last week, these were the deficiencies for dietary alone. These are cumulative, by the way. So why were hospitals cited for dietary issues? What are the final regulations that CMS has put out for food and diet? Now, CMS put out a memo back in January of 2015 to implement those final guidelines based upon the regulation. And it went into effect April of that year. And what they did was they rewrote a lot of the tag numbers. They took out one of them. And it explained the process for hospitals that do want to privilege and credential the dietitian or nutritional specialist so that they can go ahead and order a patient diet. And they did this so that they don't have to wait for the physician, that the dietitian can actually order that diet. There are other resources that are available to hospitals if they're going to look to do this according to state law. All right, conditions of participation for the diet services themselves. I'm talking Appendix A. They have to be based on acceptable standards of practice. By the way, CMS won't establish those standards for the most part. They will go through the expert. They will look at the nutrition and dietetics standard. They will look at the Academy of Nutrition and Dietetics. They will look at the American Academy of Physicians. Whatever it is that references, CMS is going to reference those. Sanitation guidelines, you also need to have those. That was one of the policies that's required. Now, this is a specific state rule. This happens to be for Oregon. And again, it's a specific state rule that talks about food sanitation. Let's move over to organization. This is the next tag number. And this is one area that was quite a few dings on it, quite a few citations. You have to have a full-time employee that serves as Director of Food and Dietetic Services. They are responsible for the daily management of the services through diet. They can be given authority and delegation by the board and the medical staff to operate and run the services. And those policies include safe handling of food, meeting the nutritional needs of the patient. That still exists, and that's in accordance with the dietary practices. Continuing with tag 629, therapeutic diets, they not only have to meet the needs, but in order to do that, we have to assess patients. What are their deficiencies? Where are they lacking in a certain nutrient? Therapeutic diets are those ordered as part of their treatment, whether it's a disease or a clinical condition. And the goal is to eliminate or decrease or increase certain substances in that diet. The patient may need a whole comprehensive assessment, and that means not only medical, surgical conditions, or even their physical status that might interfere with their ability to digest or absorb nutrients. And the patients, they also used that malnutrition screening tool and found that 51% of the patients ate half or less of their food. And that, of course, increased their risk of death. And adults who didn't eat anything had 6 times higher rate of death. Let's move over to critical access hospitals for a few minutes and talk about them. Again, critical access hospitals, you're the one 25 beds or less, and you're in a rural area at least 35 miles from the next available facility, or if you're in a mountainous region with just some really back roads, it's more like 25 miles. This is your operations manual for critical access hospital. Again, you're in Appendix W, and that's a little bit different. This is the guiding principles for developing that dietary reference intake. This happens to reference a chronic disease. The National Academy Press also talks about optimizing the process to establish the guidelines. It is 130 pages long. It's a book if you're interested in having that for your dietitian. Also previous guidelines. So let's switch over to Joint Commission real quick. And they put dietary into the provision of care chapter, PC. And there are some that do relate to dietary. It's a very important standard, and this one does focus on the whole care delivered to the patient, to the meat. And there are 4 core parts of that care process: assessment, planning, providing, and then coordinating care treatment and services. And of course, interventions are based off of that plan of care. So there isn't a separate dietary section in Joint Commission like it is with CMS. It's incorporated into the patient care section. And what they do is they first off start with assessment. What is the time frame for doing that assessment? Now, the standard is the hospital makes food and nutrition products available to the patient. Element of Performance 6 also says that we prepare food and nutrition products using proper sanitation. Sounds familiar, doesn't it? That there's temperature, light, moisture, ventilation, and security. Now, you think, why would I have to have security? Because if someone gets in and contaminates the food, you have to know about that. They also have to have there's element of performance that the products have to be consistent with each patient's care, and they accommodate, this is new, this is not in CMS, accommodate their cultural, religious, or ethnic food needs and preferences. They also have that you store the hospital's and the food and nutrition services and product in a proper temperature and light, and that even includes those brought in by patient family. What about patient education on their diet? I mean, it's one thing to give them this diet, but it's another thing that we have to educate the patient. And by the way, this includes the family. We need to include the family because if they're going to go home, they need to have that backup. I'm going to touch briefly on DNV. That is another deemed status process that can occur. It's very similar to Joint Commission and also CMS, just some different numbers. You have to make sure you have support staff, your technical staff, that they're competent to do their job and that the nutritional needs have to be met. And they're also going to ask, by the way, the surveyor for DNV will ask if you have weekend and evening coverage. And you still have to make sure everything is provided in accordance with the practitioner's order. Director of Dietary must be delegated responsibility by the medical staff and board. So if you do have someone you hire new, a new dietary director, they have to go to the board and the MEC meeting and get the thumbs up approval from both the board and the MEC. DNV has many policy and procedures that are required for them. We are concluding. I want to thank everyone for participating and listening in. And with that, I will go ahead and conclude today's webinar. Thank you very much and stay safe, everyone.